Welcome. I am Colonel Frederick Lau, Director of the Department of Defense Medical Ethics Center at the Uniformed Services University in Bethesda, Maryland. Our team has created the following presentation for your consideration. This presentation is designed to provide bioethics guidance to all Department of Defense healthcare professionals preparing for and dealing with COVID-19 medical challenges. This bioethics guide is not official policy of the Department of Defense. Rather, is intended to be a guide. The theme of the bioethics guide is preparation. Preparation for COVID-19 issues, from pre-hospital to in-hospital, and most critically for discharge, will limit both ethical and potential legal challenges. Again, what we provide is not official policy, but rather an approach we think will be beneficial. The Department of Defense Medical Ethics team at the Uniformed Services University stand ready to assist you. Our contact information is provided in the presentation. Our medical ethics team wish you well and thank you for your attention.
I welcome you to our presentation. My colleagues and I will be discussing the Department of Defense Medical Ethics Center bioethics guidance specifically related to the COVID-19 pandemic. We will focus on the ethical and legal considerations. We will be introduced by our Administrative Officer, Ms. Polly Combs.
Thank you, Colonel Lau. Our presenters today are, of course, Colonel Lau, Mr. Joseph Procaccino, who is our legal advisor, as well as an assistant professor of the Department of Preventive Medicine and Biostatistics, Professor James Giordano, who is also our bioethicist, myself, and Mr. Joshua Gerton, our deputy director. The following are a few slides on the biographies of our presenters. None of the presenters today have any financial or other relationships to the content of this presentation. Today, our goal is to provide you with 3 learning objectives. First, to recognize the fundamental ethical principles that influence decisions of allocating scarce resources. The second is to understand the legal significance of state and local laws as they relate to COVID-19. And third, to review our recommended DMEC ethical guidance to help our MTFs better deal with this pandemic. And now, Colonel Lau will present the non-policy disclosure.
This is Colonel Lau on slide 11. This is our non-policy disclosure. The following guidance is provided by experts in the areas of medicine, bioethics, and law. The comments of the panel should not be construed as the official policy of the Department of Defense, the Office of Health Affairs, or the Defense Health Agency. The bioethics guidance is non-prescriptive and is meant to aid Department of Defense healthcare professionals dealing with complex ethical challenges. The COVID pandemic is a dynamic situation and requires great flexibility and responsiveness. To quote Benjamin Franklin, by failing to prepare, you are preparing to fail. The questions included are created to address some of the challenges that may be encountered in real time at military treatment facilities. It is our position in the Department of Defense Medical Ethics Center that the better preparation, the fewer the ethical challenges, and that questions and ethical challenges are in number inversely related to the preparation. Slide 12 is the history of the Department of Defense Medical Ethics Center. The Ethics Center is sited at the Uniformed Services University in Bethesda, Maryland. The Ethics Center was established by the Department of Defense Instruction 6025.27 in November of 2017. It was created to deal with and assist healthcare professionals throughout the Department of Defense dealing with ethical challenges that had been arising over the previous numbers of years during the wars in Afghanistan and Iraq. The Department of Defense Medical Ethics Center reports through the Uniformed Services University President, Richard Thomas, to the Assistant Secretary of Defense for Health Affairs, the Honorable Thomas McCaffrey. The Department of Defense Medical Ethics Center became fully operational in January of 2019. Slide 13. According to Department of Defense instruction, the Department of Defense Medical Ethics Center has 3 tasks. The first is to create a standard ethical approach and principles applicable to military healthcare. I would refer the viewers to an article recently published entitled A Code of Ethics for Military Medicine. It was published in Military Medicine, 11 March 2020, which lays out a comparison of the Code of Ethics used by the American Medical Association with the Code of Ethics that we propose for military physicians. Our second task is to teach and promulgate medical ethics material to the Department of Defense healthcare professionals. This presentation is an element of that teaching. Finally, we are to provide real-time responses to the Department of Defense healthcare professionals dealing with ethical problems. Since the creation of the Department of Defense Medical Ethics Center, we have already dealt with a wide range of challenging ethical situations arising both in the continental United States as well as overseas, and have been able to aid healthcare professionals in arriving at the most appropriate solutions for their circumstances. With regard to the performance of the Department of Defense Medical Ethics Center assisting in the COVID-19 pandemic, the following accomplishments are listed. First, we provided consultancy in responding to a request within the military health system for use of remdesivir in hospitals in CONUS for possible clinical use, as well as use overseas in application of force protection. This was in March of 2020. Following this, we developed ethical guidance for the Department of Defense COVID-19 Practice Management Guide, both versions 1 and 2. More recently, we have created the Department of Defense Medical Ethics Center Bioethics Guidance, specifically related to the COVID-19 pandemic, and this document has been widely distributed throughout the military health system. Finally, we have responded to 19 ethical issues directly related to the COVID-19 pandemic. From an overview, as of this date, the pandemic has resulted in close to 1 million cases of COVID-19 and over 55,000 fatalities since January, with 20,000 of those fatalities cited in New York City. The future at this time remains uncertain. The biologic behavior of the COVID-19 virus is yet to be fully known. Individual testing is becoming more available both in the nation and in the Department of Defense. Yet there are immense challenges facing the Department of Defense related to induction of members into the service. Basic training and advanced training is challenging, and maintaining operational safety for units remains a challenge. And this directly relates to our impact on the military treatment facilities and medical centers. The ethical principles presented in our bioethics guidance can be useful in dealing with the issues on site in the MTFs. Another issue being faced right now is how to return to normal operations, both here at the Uniformed Services University and throughout units. The struggle is on to determine at what point and at what level normal operations can be resumed, and then how to prepare for the immediate future. Additional challenges may be the potential for a second wave of cases in the fall of 2020, and preparations in that area must be made. As DoD healthcare professionals, it is incumbent on us to be aware of the ethical principles that guide our behavior within the military context. Most importantly, both lateral and vertical communication within the MTFs and with local civilian medical centers is critical. Additionally, those MTFs sited on military facilities need to maintain and establish viable and easily usable communication with their local unit commanders, as well as base commanders, fire, EMS, and military police on their facilities. The MTF directors must also establish easy communication with their referral centers, and it is recommended that the MTF staff establish easy communication with the staffs of the local military units as well as their aviation assets to assist in discharge planning. Discharge planning is critical to proper function of the MTFs, both discharge into the community and potentially discharge to additional referral centers. Finally, importance of early preparation is critical to avoiding the worst case scenarios. By early preparation, we can avoid stress on personnel, ensure that we have adequate medications and medical technology devices to treat the individuals, and great attention needs to be paid to discharging so as to maintain the hospital at a functioning level.
Our next presenter will be Professor Giordano, who will talk to us about the primary ethical constructs and principles in application.
Thank you very much, Ms. Combs, and thanks also to you, Colonel Lau, both for your introduction and for the information you provided. As Colonel Lau alluded, per long-standing tradition, as elucidated at least in part by the wonderful article appearing in Military Medicine Journal earlier this year, the ethics of military medicine seeks to balance care of the individual patient and the mission readiness of the force. This reflects writ large the reciprocity of the patient-centered clinical encounter and the community-centered focus and activity of public health, wherein the military indeed serves that public in an open society. This balance is particularly critical during periods of crisis and limited medical available resources. To be sure, the current COVID crisis brings this necessity in balancing these types of resources into stark relief. What becomes important to understand is that critical to navigating this often trying terrain is the establishment of some form of a roadmap that creates ethically sound basis of duty. And these are grounded in both the philosophical aspects of medicine in the military and the practical and realities of military medicine. The ethical framework that we may be able to use for MTFs during this crisis essentially acknowledge two moral responsibilities. First, the duty to care for individual patients that is based upon and sustains the ethical foundations derived from a core philosophy of medicine. That is to say, the right and good care of this particular patient at this particular time with these defined needs, what is right and good. Second is the duty to equitably distribute limited resources and services that are based upon community good, because indeed medicine does serve a public good, a community good, and in this case, military medicine serves the good of the military, such that that military can then protect the polis. This becomes critical as we understand this, because toward these undergirding foundations are four primary ethical precepts that afford both a normative and applied guidance that can then be used in practical situations in military medicine and perhaps beyond. Namely, these four ethical precepts that are critical to the COVID crisis that we have are, first, maximization of benefit, benevolence, wanting to do good, beneficence, doing good as an active maxim of clinical care. Certainly, we understand that in treating the military, we're treating the military as a force, one individual at a time, but that also incurs the need to treat individuals relative to the mission of the force. And therefore, the realities of the situation is that more than likely, there are going to be particular contingencies and exigencies that must be met. Therefore, equitable treatment is a second priority. Third priority and ethical precept is the promotion of instrumental values, both of medicine writ large, right and good care of individuals' patients, and military medicine that seeks in many ways to create that balance between the individual and the collective. And last and certainly not least is the fundamental prioritization of the most vulnerable patients.
Our next presenter will be Mr. Procaccino, who will enlighten us about the ethical legal implications.
I also want to offer my thanks for the opportunity to be a small part of this presentation and I'm privileged to be with a team of such respected experts in their fields. I want to spend just a few minutes to cover what I believe are current and potential matters to consider from a quote-unquote medical law ethics viewpoint, with the sensitive issue of triage or reverse triage based on our prioritization schema. It is critical to remember the importance of advance directives. This crisis underscores the need to be sure that the provisions of the 1990 Patient Self-Determination Act are implemented and that all beneficiaries who are patients or potential patients be made aware of their rights under federal and state laws to complete an advance directive. I would also note that 10 United States Code 1044C gives advance directors of the military members and their families full faith and credit throughout the United States. Having this document available may greatly assist the providers in the care provided to a patient, as well as respecting their autonomy for end-of-life treatment should it get to that point. Of course, in dealing with potential scarcity of equipment, staff, or other resources, it is possible that the wishes of the patient or surrogate may not be able to be realized. If prioritized decisions need to be made, which may result in less aggressive care for a patient due to the gravity of her or his medical status, providers may be forced to examine the futility of continued care and balance the overall potential for recovery among affected patients with patient preferences for continued aggressive intervention. This is always a difficult decision, as it is a provider's mantra to preserve life. In crisis such as this, the mantra may be needed to be viewed in terms of doing the greatest good to the greatest number of people who have the greatest chance of recovery and benefit, as noted earlier. In this regard, it is important to communicate with your legal offices and see if there are particular conflicts with state or federal laws regarding determination of fetal care in the face of advance directives. It also begs for the need for sensitive care and communication with the patient and/or the patient's surrogates to explain the situation, what is being done, and why. Not every communication will be pleasant, but they are necessary to demonstrate that the MTF treats these patients as valued human beings and not just a number or a body. Finally, if prioritization is being made with reverse triage due to mission needs, the patient population deserves to be notified of this to the greatest extent possible, ideally prior to admission to MTFs. So it may afford some patients who have the option, the ability to go to another facility that can be implemented where such prioritizations may not be the same. It has been made clear by recent Department of Health and Human Service pronouncements, as well as the Civil Rights Act, that triage criteria should not be based per se on persons due to age, disability, or other recognized categories for non-discrimination. While those factors may come into play in the overall assessment of a patient's ability to withstand aggressive treatment and have a reasonable chance of recovery, they again should not be factors in and of themselves. Triage and prioritization bring to light the ethical principle of justice, or essentially treating people equally. Obviously, in a perfect world, we would strive for this. In crisis situations, however, we may have to look at the concept in a similar way public health providers do in balancing the care of one person versus the health and safety of the community. In this regard, while choices for prioritized care may need to be made in certain circumstances, those decisions should be based on accepted medical criteria for assessing the patient and the chances for recovery. In extreme situations, preference in care for healthcare workers, first responders, or active duty may need to be considered, as these individuals, if their medical assessment indicates that they can recover to continue to treat others, or in the case of active duty, be returned to essential national security missions, may be justified as benefiting the whole. That having been said, I would caution on how such prioritizations, particularly in the military environment, are made. We often see, for example, our military treatment facilities having VIP wings or executive care for certain members and their families. Should someone's grade or rank or their official status or the family of those individuals be considered for prioritized care? Is there truly a mission issue that would dictate such for this virus? Finally, we need to be cognizant of the providers themselves, who are not only putting their own lives at risk in the care that they give, but also suffer emotionally from the long hours and the tragic deaths they may witness. Often, when they must be the surrogate for the family who cannot be in the room to say goodbye to a loved one. The law and the Department of Defense policy recognize conscience clause objections for providers who believe that what being asked to do may violate their own religious or moral principles. While this remains true, there may be value in trying to ascertain beforehand if providers assisting in triage procedures do have such objections in making prioritization decisions. Doing so will avoid acute problems at the bedside for needed staff. Further, it is possible, based on many reports from the civilian sector, that providers may be asked or even ordered to work in dangerous environments that will contain improper or inadequate personal protective equipment or shortage of staff, thus putting their lives at risk. If they refuse to work in that environment, might that refusal result in adverse consequences or result in adverse administrative actions or even from military, Uniform Code of Military Justice actions? Would an order to work in that environment be deemed legal for civilians, from military? Again, this shows the critical need for working closely with your legal counsel. These are all difficult decisions to confront, but they need to be on the table. We now move to the next slide. Regarding specific legal issues, facilities will need to be cognizant of all applicable federal, state, and even local laws and regulations in treating COVID-19 patients. The civilian non-beneficiary patients are allowed to be treated in military treatment facilities per proper authorization. They will have the same rights to seek administrative and legal redress as beneficiaries. In addition, military and other federal providers and support personnel are being or may ask to be tasked to work in non-military facilities or environments. In these situations, our providers may find certain facility-unique standard operating procedures and should accommodate those as best possible. While federal healthcare providers, including military and federally approved volunteers, have legal liability protections afforded them under federal and in some states where they are assisting in emergencies, state law, they must remain practicing in the scope of their federal employment or line of duty for those protections to apply. Further, it is important to maintain appropriate credentialing and privileging of providers where appropriate, and ensuring that military personnel assisting in civilian environments have the proper competencies to be doing their assigned tasks. Finally, new technologies may bring new ethical and legal questions to the forefront, such as use of smartphone screening for contacts or distancing. These will need to be assessed for their overall need versus the right of privacies of individuals and perhaps national security interests. This is why it is critical to involve MTF in base or post-legal support, along with quality assurance personnel and counseling providers, as well as seeking their assistance for any incident that has the liability potential. Further, Defense Health Agency legal personnel and for overseas or operational units, service medical law specialists are invaluable in offering advice and assistance, and they should be the ones to be consulted. Thank you.
Thank you. Our next presenter will be Mr. Girton, who will tell us about preparation and coordination.
Good day. Thank you, Ms. Combs. I'm Josh Girton, the Deputy Director of the DMEC, and I will be beginning my presentation on slide 19. First off, thanks kindly to everyone for watching our presentation. Thanks also to my impressive DMEC colleagues for their time and expertise. I'd also like to congratulate Colonel Chung and Lieutenant Colonel Matos for putting together such a comprehensive and useful tool in the DoD COVID-19 Practice Management Guide, which I will reference throughout my comments today. You've already heard some great commentary from the other presenters in regards to the current SITREP on COVID-19, as well as some good general guidance regarding ethical principles and legal implications. My objective is simply to review some of the more practical considerations that were contained in our DMEC bioethics guidance on the COVID-19 pandemic. That document can be found on our DMEC website, and the hyperlink is listed on the final slide in this PowerPoint presentation, which also contains all of our contact information. Our DMEC bioethics guidance proposed a non-prescriptive framework and strategy for constructing your triage planning committee and triage teams in consideration of the various ethical principles involved. Obviously, these are just general suggestions for potential implementation, but you still need to tailor them to your specific facility if clinically logical, feasible, and legally permissible based on your own circumstances. Our DMEC bioethics guidance also needs to be read in conjunction with the controlling DoD COVID-19 Practice Management Guide, other DHA guidance, and in coordination with your local MTF legal advisor and/or DHA Office of the General Counsel. But the suggestions contained within the DMEC bioethics guidance have been incredibly well researched, are in line with the prevailing bioethics experts, and are well measured in presentation. As Colonel Lau said to me the other day, any document can be improved at the sacrifice of time, and often perfect is the enemy of good. So we wanted to present some actionable guidance to you right now, which can be further refined going forward. The COVID-19 pandemic will require a well-integrated MTF response, which is why our DMEC bioethics guidance suggested specific duties for defined personnel within the MTF in response, to include the MTF director, the MTF chief of staff, the MTF medical ethics committee, the MTF senior medical service corps officer, and the MTF legal advisor. Again, the objective is to prepare your respective facilities to avoid any future crisis conditions to the greatest extent possible. Obviously, these recommendations would be as equally as relevant during the initial wave of the pandemic or secondary outbreaks in the event of future resurgence as communities begin to relax their respective quarantine measures. As Mr. Procaccino already mentioned, the MTF legal advisors will be of critical importance in response in order to ensure consistency with the relevant jurisdictional laws and regulations in play. This is particularly true to ensure that the MTF triage procedures are not discriminatory against protected classes of individuals, i.e. the elderly, persons with disabilities, as was alluded to. Given the unpredictable trajectory of the COVID-19 pandemic, it is vital to coordinate with local civilian medical centers in anticipation of a potential community level response. It's also critical to stay attuned to the triage SOPs of the highly reputable civilian medical centers in your geographic area, which will likely be a good indicator of compliance with local laws and regulations and can be further confirmed by your local MTF legal advisor and/or DHA OGC if need be. The DMEC bioethics guidance does recommend that countermeasures should be implemented to reduce the moral distress in healthcare professionals, patients, and families alike. To that end, there are some high-quality references in the updated version of the DoD COVID-19 Practice Management Guide to assist your MTFs in this regard. In addition, from our conversations with civilian medical centers who've experienced high patient volumes in the COVID-19 pandemic environment, they strongly recommend that MTFs ensure that hyper-focus is dedicated to discharge planning process, the drug and blood inventory supply levels, and the availability of dialysis machines, which can quickly become the Achilles heel that overwhelms the MTF. I'm now transitioning to slide 20. The DMEC bioethics guidance does contain a listing of factors to consider in the CPR context, and one of our questions later in this presentation in the Q&A section is derived from an ethical scenario focused on this issue specifically. So you will have the opportunity to hear the panel members give their insights in regards to whether or not to perform CPR in certain situations, the appropriate level of PPE required, the number of individuals on the code response team, special considerations if the patient is particularly large or heavy and or lying on their stomach in a prone position, as well as a potential futility determination. The DMEC bioethics guidance also contains some commentary on considerations in the palliative care context, and pre-planning seems to be a critical message in having patients speak with their families beforehand about their stated desires. Finally, the DMEC's bioethics guidance contains and discusses the ethical principles surrounding the potential triaging priority of MTF healthcare professionals from a continuity care and medical operability perspective, and active duty patients from a force health protection perspective. However, as was alluded to by Mr. Procaccino, in both of those instances, it would be critically important to communicate those prioritized triage SOPs to the impacted patient population to empower them to make their own decision in advance of actually seeking care at an MTF. It is also equally important to ensure that your local MTF legal advisor and/or DHA OGC is consulted in operationalizing these types of decisions to ensure consistency with the relevant laws and regulations. That concludes all of my remarks. Thanks kindly for your time and attention. I'll now turn the presentation back over to Ms. Combs to present the Q&A scenario.
Our first question will be for Mr. Procaccino. In pandemic crisis situations like this, which offices and specialties are recommended to be points of contact for potential issues?
Needless to say, when a crisis like COVID-19 occurs, you don't normally think of the veritable plethora of offices within and even outside of the MTF and the military installation that may have critical input in the successful treatment and care of patients and providers. Among the entities that you should consider for communication and collaboration purposes, and to try to have these kind of on your phone to be able to contact immediately when something like this happens, would be obviously the departments of the medical specialties that are involved in the care and treatment. Also critically, as I noted earlier, your local legal offices that can offer legal consult and advice to you on a multitude of issues. You need to also bring in your quality assurance personnel because, as mentioned earlier, there may be numerous credentialing and privileging issues which come into play not only for the personnel in the MTF, but for instance for volunteers, or if MTFs are sending their folks out to the civilian environment. We need to remember also something as important as bioengineers within the facility. We're noticing news reports of medical providers that will be leaving their shift at a hospital and taking off their gloves and masks and just tossing them aside, not thinking about the potential problems that can occur with these not being put in sanitary conditions for disposal. And also making sure that the ventilation systems, that other issues involving separation of patients and providers can be handled. And this is really an engineering issue. Also very important is healthcare resolution. Fortunately, the Department of Defense has an entity called the Healthcare Resolution Program, and there are specialists regionally that can assist military treatment facilities for issues regarding communication between provider and patients when there are concerns and problems that arise. And these individuals can also be extremely helpful in considering the provider as a second patient or even victim quite often. Tantamount to this, or at least in coordination with this, one should bring in mental health assistance, not only for patients, but for providers as well, because of the high stress levels that are involved. Needless to say, medical command must be constantly involved in the ability to be able to direct all of these appropriate officers to be able to do what they need to do. And not only medical command, but coordination with line command is critical here. Also taking into account, however, any laws or regulations involving privacy of patient information and what can and cannot be transmitted. In addition to this, if the facility has ethics or triage committees or teams, they need to be activated. They need to be part of the decision-making process as appropriate. We shouldn't forget the chaplainate and the agencies that offer moral and spiritual comfort not only to patients, but also providers as well. Mortuary affairs will play a very critical role in this, and they must be able to coordinate the activities inside the hospital for proper disposition and removal of bodies when necessary. And again, public affairs, because of the implications of dealing with a federal environment, may need to be alerted as to what is happening not only inside the facility, but outside the facility, so appropriate, say, news channels or other entities can be brought into play. I would finally also mention, as other speakers have noted earlier, the importance of coordinating with local hospitals and local public health offices, so we're all speaking with the same voice and communicating. This is not only important from a healthcare standpoint, but also helps to ensure common standards of care that are being used within the locality. Finally, I would also mention that the security or military police on the installation, as well as the fire department and emergency medical service teams that may not be directly affiliated with the hospital, but tangentially part of them, be brought in too because of their critical role. Not only admission into the base or into the medical facility, but also the ability to respond quickly to emergencies that occur, not only on the installation, but also, if asked, even outside the installation due to the emergent conditions. Thank you, Ms. Combs.
Thank you, Mr. Procaccino. Professor Giordano, in a crisis situation with a drastic shortage of responsive medical resources, is it permissible to remove a patient from a ventilator support and divert it to another patient who has a greater chance of surviving?
Thanks very much, Ms. Combs. That's an essential question, a very critical one, critically in the literal sense in terms of these patients' critical condition, and the fact that very often our decisions and actions are going to be criticized. I think in these circumstances, it's important to regard crisis also in its literal sense. It's a time of change, and under crisis conditions, we have to address the change from day-to-day situations and the need to change from day-to-day situations, events, capabilities, and capacities. Thus, a crisis capacity situation refers to an extreme scenario in which all of the varying but very critical resources of the ICU, beds, ventilators, protective equipment are in use, and new patients are being continuously triaged on an ongoing basis. Under these circumstances, and let me be quite clear, it may be ethically permissible to divert life-sustaining treatment from a patient who is deemed less likely to benefit from the ongoing application of limited resources for example, under conditions of futility, toward a patient who's more likely to survive. Obviously, this is not going to be an easy decision, and it's a decision that weighs upon a number of different factors, ranging from the medical to the moral, and those are not mutually exclusive. This is a condition that needs to be taken with the greatest respect for human life and human dignity. And it's a recommendation that also requires consistency with individual state laws, and obviously should involve, when and where possible, a team decision that's in continuous consultation towards the execution of the decision itself.
Thank you, Professor Giordano. The next question will be answered by Colonel Lau as well as Professor Giordano. What considerations should healthcare professionals consider when determining if and how to initiate a CPR code?
Ms. Combs, thank you. This is Colonel Lau. That question is a critical question and one faced by all healthcare professionals in the emergency rooms, ICUs, et cetera, particularly in the COVID-19 crisis. Determination of initiation of CPR should be clear for every patient. Information should be sought from the patient on arrival, from their family and their caregivers as far as what is their desire, and what are their needs most likely. It is critical that that information be obtained early before the patient becomes too ill or when the families are dispersed. And it should be assumed in the absence of a declaration of no CPR that all patients are eligible and could benefit from CPR. The burden then will shift to the healthcare professionals who should be intimate in the knowledge of the patient's progress, course, and anticipated recovery, and that information should be as communicated to the families as much as is practical given the situation. Finally, the hospital command, the MTFs, and the triage committees, et cetera, should be kept apprised of the patient's condition and what their status is, and if there are changes in the clinical situation, should their CPR status be adjusted. A constant updating of this information is critical. It is difficult in busy emergency rooms and busy intensive care units where patients may be moving quickly from place to place, but nevertheless, it is critical to maintain that information. And so to answer the question, it is appropriate to initiate CPR in the absence of a declaration of no CPR or limited CPR as indicated by either the patient's clinical deterioration, patient's wishes, or the family. Dr. Giordano?
Thank you, Colonel Lau. Simply to reiterate what you said, because each and all of the points you made was spot on, I think it becomes important to remember what we like to consider the 4 C's. It's important to communicate. It's vital to coordinate. Constant updating of the situation as it evolves in real time is essential. And then as various acts of medicine are engaged, whether to perform CPR or not perform CPR, confirm facts that were important to the decisions and the actions, and then confirm those things after the fact, so that in fact we can then observe the consequences of our action and then guide them appropriately in the future. Thank you.
Thank you. Colonel Lau, in discussing the problems that have arisen in responding to the treatment of COVID-19 patients in other densely concentrated areas like New York City, what have some of the lessons learned been?
Thank you, Ms. Combs. This is Colonel Lau again. I'll answer from information that I gathered from a conversation which was had between members of the Uniformed Services University staff and one of the busier hospitals in New York City. Within the last month, that hospital was facing a tremendous challenge of large numbers of patients, huge demand on the facility, overburdened nursing staff, and difficulty discharging patients. And they had reached out to the military to inquire regarding lessons learned in Afghanistan and Iraq and how to maintain staff morale under difficult circumstances. And it was clear in conversation that the staff, physicians, nurses, and all the personnel at this hospital were doing above and beyond what was humanly possible to care for a desperate situation. But I did take away some lessons, and it's important that members of the military community keep these in mind. In my own view, ethics and leadership are two sides of the same coin. And in the Department of Ethics Center, we focus on ethics, but often the issues of leadership arise. And in this hospital situation, I think there were challenges to leadership in that the staff felt that they were not being protected adequately, that there was danger of exposing their family members to the illnesses. And it was a situation in which the staff was really carrying more than they could bear. So I think it's important that we in the DoD and in the military treatment facilities remember that our staff members are highly resilient, flexible, and are strong, and yet they need to be attended to, and that the leadership needs to be in the trenches, if you will, that the leadership of the hospitals in medicine, surgery, nursing, certainly in the command suite, need to be seen on the wards, need to be seen taking risks, need to be seen using the PPE and being aware of the situation that the caregivers are facing minute to minute, day to day. And that way they will maintain faith and allegiance with the members of their team and maintain their own resiliency. Another lesson I took away was the importance of discharging. This facility was having difficulty. They had patients in palliative care. They had patients who could go home physically and medically, but they couldn't go home because they'd been exposed to disease. They had other patients who were elderly but couldn't go to nursing facilities. So again, I've emphasized in my presentation the importance of discharge planning and discharging patients, because any system that takes in more than it can get rid of will become jammed. And that was a situation that this hospital was facing, and that will compound stress on the staff. So while the emergency rooms and the front door of the hospital are critically important, of more importance is how to discharge patients and having patients leave the hospital. This is true in combat situations or in military treatment facilities. So there were many lessons to be learned from this hospital as they struggle with their situation. We did give them some assistance with counseling, et cetera, for our staff that we found of value in combat, but it was an illuminating experience to talk to the members of this team dealing with this situation. Thank you, Ms. Combs.
Thank you. Professor Giordano, what specifically should MTF directors do to ensure their MTF healthcare professionals are not overwhelmed by burnout or moral distress to the greatest extent possible during these COVID-19 crisis periods?
Thank you very much. Well, as Mr. Procaccino addressed and discussed previously, the concept of burnout and the reality of moral distress under these circumstances, these crisis times, and the burdens that are placed on very resilient healthcare providers is overwhelming. Long shifts, high levels of morbidity and mortality among patients, and increasing morbidity among the caregivers themselves. Obviously, the resilience of those caregivers is going to be important to the provision of the services that they provide. But to paraphrase Aristotle here, realistically, ethics and virtue and leadership are really representative of the same continuum of excellence. Leadership is important. Leadership here will be vital to both the service and the support of these caregivers. And in that regard, I think what becomes important for our listeners to understand and for commanders to understand is the acronym PERCI. P-E-R-C-I. Effective leadership in preventing and dealing with moral burnout, moral distress involves a provision of encouragement. We all need that encouragement. These are individuals who are heroes, both small and large, in their daily tasks. And those daily tasks and the crisis capacity and situations very often are Herculean. Realistically, we understand that along with that comes recognition of specific actions, not just generalities. You know, we talk about earning that medal, so to speak, and yeah, that's within their job parameters and job description. But very often what we see is these individuals are going beyond what is expectational and doing the supererogatory, not only because it's their job, but because they feel it's their moral imperative. Equally important there is camaraderie, leaders working as comrades in arms, if you will, understanding that we're all vulnerable with the different parameters of our vulnerability and the volatilities that those things that may, in fact, induce our breaking point and our burnout point. And when that does happen, counseling is critical. Obviously, that's not always going to be available, but as and where possible, counseling can very often provide the bridge between teetering on the edge of moral distress and burnout and a viable recovery that allows an individual to return to work with increased vigor. And last but certainly not least is information. We're dealing with healthcare practitioners, and very often there's a sense of stoicism, I can do it, a can-do attitude that they embody and they enact. And as a result, sometimes it's important for them to take care of self in ways that they feel are most appropriate. In more personal moments, the idea of compartmentalization certainly is rife within the military, and very often our people don't want to show those stressors, even before they get to the point of where it's moral burnout. Everything's okay, I can do this, so to speak, and suddenly they find themselves precipitously at the edge of the cliff of personal crisis. We can provide things like readings for them, and certainly the MTF Practice Management Guide provides that set of resources. But resources beyond readings, perhaps in some cases, a referral to those resources for counseling, to talk to others, or even just command counseling, to debrief at the end of the day for the necessary attaboys. And as simple as that might be, the Bravo Zulus very often are important in that recognition. So once again, remember that acronym PERSI, the provision of encouragement, resources, camaraderie, and counseling, and information. And I think that's important not only for leadership, but to execute the necessary care that our caregivers provide so as to keep them from harm's way as much as conceivably possible.
Thank you. Colonel Lau, the discharge planning process, dialysis machines, and blood supply inventory are mentioned in the DMEC Bioethics guidance as possibly becoming the Achilles heels for the MTFs. What are some strategies to prevent this occurrence?
Ms. Combs, thank you very much. And as I've already articulated at length, discharge planning is critical. So as MTF directors and staff, if there is the onset of a surge of cases in your area, the critical that attention be paid to discharge planning. Additionally, one should look at one's facility and get an accurate inventory of the critical machinery that might be needed, such as we've mentioned dialysis machines, but ventilators, blood supply, and what is the mechanism of resupply. This is where if you're an MTF on a base with a large unit, an Army division, assets from our naval colleagues or Air Force, link with their aviation assets so that you may be able to fly in or access additional resources that would be outside of your area. Essentially, what it requires is what required of any military commander, which is great creativity and awareness of your situation, awareness of the strategic situation as well as the tactical, and an awareness of where potential weaknesses and what assumptions you make. And usually the assumptions are where you'll make a mistake. So to reinforce those areas which may be exposed if the patients come in large numbers. So again, it is a matter of preparation and planning and looking at the facility and planning for contingencies, as well as having a flexible and capable staff to assist. Thank you, Ms. Combs.
Thank you. Another question for you, Colonel Lau. What counsel would you provide MTF directors if civilian healthcare facilities turn to the MTF for assistance in combating COVID-19? Should they open their doors to non-military health system beneficiaries?
Ms. Combs, thank you. As been stated many times, the country faces a great challenge with the COVID-19 pandemic. And certainly the Defense Health Agency and the military have stepped forward in assisting. Examples have been to send the USNS Comfort and Mercy to Los Angeles and New York City, as well as constructing hospitals and military facilities inside locations such as the Javits Center in New York City, convention halls around the country. So there's already a mixing of military and civilian assets. Here at Walter Reed, the idea was floated that Walter Reed could be volunteered as a situation similar to the Comfort for the state of Maryland and for Baltimore. So the military facilities have already reached out and are aware of their local circumstances and have volunteered to participate in civilian care, either with offloading of cases from the civilian situation so that the COVID patients could be cared for there, or more recently, COVID patients on the USNS Comfort in New York City. So it is both appropriate and from a national standpoint to see the military facilities as part of the system, and to recommend that the military treatment facility directors link closely with their local civilian colleagues in their centers and work together to provide the most benefit for the most, to the most good for the most people. Thank you.
Thank you. Our final question is for Professor Giordano and Colonel Lau. Often there can be a gradual degradation of quality as resource scarcity worsens. What is your advice for providers in resolving this dilemma?
Thank you very much. Crisis capacity, function, and response, I think, should and perhaps can be viewed as what's called bricolage. It's a French term, and it means doing the best with what you've got. In some cases, what this drums up is what we might consider somewhat tongue-in-cheek to be a MacGyver mentality. For those of our listeners who are old enough to remember the MacGyver television show, he was an operative who could essentially build a helicopter from a set of toothpicks and maybe a paper clip. In other words, what do I have at hand? What can I use and how should I use this? But I think what's important to understand is in navigating this, one must keep, quote, eyes, if you will, on the task. And to do that, I offer 3 eyes. Number 1, identify what needs to be done. Number 2, engage innovation so that you can use the resources available in key, creative, and innovative ways so as to waste not and want not as best as conceivably possible. And the 3rd eye is the provision, acquisition, and deliverance of information before, during, and after the decisions and actions. What was the situation? What did you have at hand? What did you do with what you had at hand and why? Moral and technical justification for what you used, and then debrief what happened. And this can then serve to propagate that information and intent as lessons learned going forward. Colonel Lau, over to you, sir.
Professor Giordano, I could not say that better. That was excellent. Thank you very much. Really, the military essentially wrote the book on triage and doing the most and the best you can with what you have. I would recommend the listeners look at the Emergency War Handbook, Chapter 3, which dictates and describes triage and doing the best one can with what resources one has available. This is true in a military and a combat situation, and it is equally applicable in an MTF in the United States facing large numbers of sick. You have to maintain control of the situation, provide the leadership that's necessary, operate within an ethical framework, and constantly assess your resources and do what is best one can to reestablish what can be normal. The final thing, which I think is important, is to document what you're doing, because in the end, when the situation clears, the question will be, what did you do and what were you facing? And at that point, it'll be difficult to reconstruct. So as best one can within the time constraints and the circumstance one is facing, it's important to document what was actually happening, what resources were available, and what gaps were identified and what one did about those gaps. Thank you.
Thank you, Colonel Lau. Now we would like for you to give us some key takeaways.
Ms. Combs, thank you very much. This is our final slide, number 22. It's what we think are the key takeaways for our presentation, and I will read those to emphasize how important they are. The COVID-19 pandemic is an incredibly disruptive and continuous evolving phenomenon that will require great flexibility and resilience in both planning and execution. Understanding the overarching ethical principles and legal constraints in play is critical to crafting the appropriate military treatment facility responsive protocols. Finally, if you need any direct assistance at any time on either the ethical or legal considerations, we, the Department of Defense Medical Ethics Center, stand ready to assist you in any way possible. I'd like to thank all members of the team, Mr. Gurdon, Mr. Procaccino, Professor Giordano, and Ms. Polly Combs for their dedicated work helping the Department of Defense medical healthcare professionals deal with the situations that are challenging throughout the world. We are here to help all those healthcare professionals in the Department of Defense for the benefit of all the service members in the Department of Defense. Thank you very much for your attention. Be safe and be well. Thank you.
Thank you, Colonel Lau. The last slides show the references from our medical guidance, biomedical ethical guidance. And our final slide is our contact information, as well as the link to our DMEC bioethics guidance for the COVID-19 pandemic. Thank you very much.
The Department of Defense Medical Ethics Team hopes that our bioethics guide will stimulate all Department of Defense healthcare professionals to prepare, and we stand ready to help you at any time, and on behalf of our team, we wish you well.